Okay, so Josh, if you're okay, it's going to be live streaming on YouTube as well. And that probably means it records on YouTube, I think.
Okay, it doesn't scare me.
Is that okay? So just in case you've got any patient sensitive things to show. Josh, if you're okay, it's going to be live streaming on YouTube as well. Whoops.
Something happened, Len. There's a bit of a lag in your voice now.
It should be gone now. That was because it was reverberating from the live YouTube video link. So I've turned that down. Right. Okay. We'll let Josh. I hope you're not. Josh looks lost.
I'm lost in my own apartment. They're actually. I'm back in the city. They're doing construction, and it was loud, so I'm going to find a more quiet place. Give me 1 second.
Okay. Well, good. I think
I'm using my daughter's room.
No problem. Okay. Well, Josh wanders aimlessly. Just say welcome to everyone. Thanks for coming. This is our first use of the paid version. So Josh is our experiment, and it's a massive thank you to Josh for doing this. We've been running these for a few weeks in-house, but with having a guest speaker, we've opened it up to the Northwest Upper Limb group, and thanks to those who've signed up so far. What we're going to do is quickly, before we start and formal introductions to Josh, is we've just got a couple of polls. So I'm going to launch the poll, the welcome poll, for you guys. So you should see that now. So what we want to know, firstly, what are you? Are you consultant, surgeon, trainee, AHP, or an imposter? And where did you hear about the webinar? So either the email or the Northwest Upper Limb group. Can you guys see the results as they're coming in?
I cannot.
Okay, right. Hopefully I'll be able to share the results with you. Right, okay, so it looks like the vast majority came via the fellow and MCH WhatsApp groups, and we've got a 50% consultants, surgeons, 42% surgical trainees, and 8% AHPs at the moment, but people are still gradually, slowly coming in. So there we go. You should be able to see those results now. Fantastic. And great. So I'll just need to close that. Sorry, be patient with me. Now, good. I can't seem to find your poll, Josh. Sorry about that.
It's okay.
We'll come to that hopefully later on. So everyone, I'd like to introduce Josh. I know Josh well from the circuits and visiting him in New York and conferences, and always been in awe by his research and his lectures. And Josh, you might not know, but we actually reviewed one of your papers in our journal club yesterday on the critical shoulder angle, which was fantastic. Josh also comes from a shoulder surgeon dynasty. His father David is a household name in shoulder surgery, and Josh is certainly becoming one. So thank you very much. I'll hand over to you, Josh, to give us your talk. Thanks.
Sure. I'll try to. So let me see if I can share the screen now. See if this should work. Oh,
Okay.
can you make me the host for a second, Len?
Yep.
Okay, perfect.
I'd just like to say to everyone, any questions whilst Josh is speaking, you'll see the Q&A button at the bottom. If you put your questions into the Q&A box, and then Josh will answer them after the talk. So as he goes through the talk, put any questions in the Q&A section. Thanks.
Sorry, just setting this up. Can you guys see my screen okay?
I can see it perfectly. Mike Pinney?
Yeah, can see it nicely. Thank you.
Great.
Yeah,
So-
mine's great.
Oh, thank you. Thank you for having me. This is definitely, it's easier than traveling, so it's great. And it's a great way to see, I've gotten way too comfortable with Zoom over the last 2 months. But I'm honored to be the first paying user. That's good. I feel flattered. And I thank Glenn for the introduction. He's, it's been great getting to know him on kind of just different shoulder meetings. And this is not, not blatant ass kissing. Your talks are always great. I'm always taking pictures of your slides. They're always funny and thoughtful. And I don't do that for everybody. So it's an honor for you to kind of include me and say the nice things you did. Len and I were talking about what to discuss. We thought, instead of one long talk going over everything we'll do, 2, one is more than Bancorp, but less than Latarjet. And I know this is maybe a New Yorker America bias in that, some of my colleagues in Europe will just do a Latarjet on every case of instability. In America, we were probably the other end of the extreme for a while, and now meeting somewhere in the middle. But I'm going to kind of try to walk through my algorithm, which I admit is a moving target because we don't have all the answers, but we'll try. So I'm at HSS in New York City, Hospital for Special Surgery, which is just an orthopedic hospital on the Upper East Side of New York. There's 130 orthopedic surgeons. I think that it's a ton of joint replacements. We do, I think, 1% of the world's hip and knee replacements as a small hospital on the Upper East Side of New York. There's over 327 active medical staff, including a lot of fellows, residents. We've got 9 shoulder sports fellows. There's 10 residents a year, so it's a lot of people. And at this point, the slide's probably a year or 2 old. Probably, almost 40,000 surgeries a year, all orthopedic surgeries. It's always very highly ranked in America, both with regards to it being a hospital and the residency program. So, I'm very proud to work there. And in New York, we basically take care of every major sports team and then a lot of the national teams as well. So I do a lot of shoulder surgery, and my interests are, shoulder, soft tissue injuries, a lot of rotator cuff and instability. I do treat a lot of young athletes, so shoulder instability becomes one of the more common things that I treat, and in some cases, sort of the bane of my existence. But as I try to figure out, an appropriate algorithm to treat these athletes. So we do know, but as way of review, obviously this typically affects younger patients, and it's very common. Rugby, basketball, it's not uncommon. Ice hockey. So when you're treating these athletes, it sounds cliche, but the history is very. Is this happening as the result of a tackle in football, or is it happening when they're sneezing in the middle of the night? That's going to kind of set off some treatment with men. What are the goals of the patient? And very important, as we know from the literature, is what was their age at the first dislocation? Because that's also going to help us predict if it's going to happen again, and maybe whether or not we should get a little more aggressive in terms of treating these. Physical exam, for the residents and the top, if somebody dislocates yesterday and I'm seeing in the clinic, physical that I'm going to see if they're apprehensive. I'm not going to do a load and shift. I don't want to try to re-dislocate their shoulder. But even in those cases, laxity, are they ligamentally lax at baseline? Are they unstable at mid-ranges of motion? These are going to be important factors. Obviously, good preoperative imaging is critical, and usually that's an MRI for me. But if I'm concerned about bone loss or revision cases, CT scans will provide a lot of helpful information. Just to set kind of as a backdrop, my go-to for the majority of instability cases, probably 90%, maybe 85%, would just be an arthroscopic Bankart. This is done in the beach chair position, though I've actually switched. I do most laterally now. But either way, whatever you feel most comfortable with, the principles are going to be the same. We're looking from the posterior portal here, looking anteriorly. I've got the elevator, mobilizing the torn labral tissue anterior inferiorly on the glenoid there, consistent with a Bankart lesion. I'm now going to use a mechanical shaver to just abrade the neck of the glenoid to enhance healing potential. And then you see, you can see the IGHL. You've got a good, the tissue quality is good here. I didn't do, oh, sorry. Sorry, good tissue quality. I didn't show, but there was no significant bone loss on the glenoid, nor on the humeral head. So this is somebody, that I think is going to benefit from an arthroscopic Bankart with pretty predictable results. Obviously, the principles are going to be, doing a superior, both a shift medial to lateral, but also inferior to superior to take the tension and retension that IGHL. Here I'm doing a mattress suture, and this is going to be a knotless anchor. But again, whatever you feel comfortable using is more than fine. Here's the mattress configuration. I've got a good grasp of the tissue. Drilling my pilot hole just off the face of the glenoid there. And with the knotless anchors, you almost have to bring it up onto the face a little. If you're tying knots, I'm very particular about being off the face. With the knotless anchor, just the way it brings the suture in, I kind of drilled just off the face of the anchor. I'm going to impact it here that you'll see. We'll cut the suture. And then that was a good place to fast forward to. It made it look like a mess of sutures, but I swear I knew what I was doing. But then I just work superiorly. I do a mattress one on that first one. I'm going to mattress this one again. And again, very good quality tissue here. Not a lot of bone loss. So I think, I'll skip ahead just in the interest of time. I like to be able to get at least 3 anchors, and that's based on a lot of the literature that will show if you're using less than that, you're probably not, you're at an increased risk of redislocation. So this is that 3rd anchor going in. I'll cut that suture. And in this case, I've reestablished good anterior bumper. I've taken away that drive-through sign. And if we look at the literature, I think with these newer techniques or more modern arthroscopic techniques, sutures and anchors, we've probably reduced the redislocation rate to about 8 or 9%. Now, the problem for me is that's great, but that still means that, let's round up 10% of the time, there's going to be a redislocation. And what I explain to patients is that we're not making you into Wolverine. So look, we're not going to make you indestructible. If you're going to go back to playing contact sports such as football, things of that nature, there's always the risk of a redislocation. But the closer we can get it to 0, the better. So I think that has caused us to sort of get a little more granular to look at why these were failing. And it's never going to be perfect, but maybe we can reduce that redislocation rate to 3 or 4%. So what are the reasons? Well, bone defects I alluded to, both on the glenoid and the humeral head side. The inverted pear-shaped glenoid. And Steve Burkhardt and Joe DeBeer did a great series on this. And they looked at 200 patients without bone loss with an arthroscopic stabilization, and there was a 4% recurrence rate, which is, again, I think very acceptable in the athletes we're treating. The problem is that the 21 patients with significant bone loss, almost 2/3 of them recurred, and that's blatantly unacceptable. So they begun using the Latarjet for 25% bone loss, and they had a 4% recurrent instability rate. So again, I think they really helped for the American surgeons, the North American surgeons, put on the map that there's going to be a group who's going to be at a higher risk for recurrent instability, and maybe we need to do more. There's clearly, multiple studies have shown a clear association between significant glenoid bone loss of 25%, and now even less than that, probably 13.5% if we look at the more recent work by J.T. Tokish with failure after arthroscopic Bankart. And again, if we looked at the presence of bony defect in these series, unacceptable redislocation rates. So we've gotten a little better about predicting the risk factors for failure. I mentioned bone loss, that's one. Contact athletes, males as opposed to females, younger age. Earlier, I mentioned the number of previous dislocations. When you get above 3, they're going to be at a higher risk for failure after an arthroscopic Bankart and bone loss. Contact athletes had a 2 to 3% higher incidence of failure versus open. Males, females had about a 50% redislocation rate at the age of 15. Men, that number stayed as high up to the mid-20s. So, maybe a reason to get more aggressive by stabilizing a first-time dislocator in the males. Younger groups, again, that's on that same slide, but the number of previous dislocations becomes a real significant predictor for failure of redislocate or for failure of arthroscopic surgery if they have more than 3. So why not use the Latarjet procedure on everybody? And that's what Jill Walsh and a lot of my mentors and very thoughtful people would argue. And they, just as way of review, it works via 3 ways. One is the bone block effect, where you're transferring the coracoid to the anterior aspect of the glenoid. The sling effect with the conjoint tendon, basically lowering the inferior half of the subscapularis as you bring it to that apprehension position. And the bumper effect, where you're reinforcing the capsule with the CA ligament. Well, we looked at this in the lab in Ty Lee's lab to figure out what exactly was working. And we published this in JSES. And we found that and I think, to be fair, it probably functions, the Latarjet probably functions differently in different settings. So in the setting of bone loss, transferring the coracoid is probably doing a little more than when you're doing it just for capsular insufficiency. So that's what we looked at in the lab. And when we looked at a Latarjet done just for soft tissue insufficiency, the conjoint tendon is really what provided the stabilizing effect. Now, again, this was not a bone loss model. Gilles' results have been excellent. If we look at his series of almost probably at this point, 3,000, his recurrence rate is less than 2%. And that's great. So I think everybody would sign up for that if you could promise your patients that. The problem is, Gilles' an outstanding surgeon. So I don't, his results may be more difficult for others to reproduce. And if you're not reproducing them, there are issues. So, this was a study by Christian Gerber looking at Latarjet versus Bankart. Again, making the point that he looked at an open Latarjet for 93 patients, Bankart for almost 3 times that amount. And to be fair, he tried to, not have a selection bias that would be biased towards Latarjet. He did the Bankarts only in those patients who had less than 10% glenoid bone loss. And the recurrence rates were extremely high in the arthroscopic Bankart group. So he concluded that the effectiveness of an arthroscopic Bankart decreases over the postoperative course and leads to a substantial number of late failures. Therefore, he did not recommend an arthroscopic Bankart to his patients who have anterior dislocation. So a good conclusion, I think we can get a little more granular here. I mean, I think that 41% arthroscopic Bankart failure rate is extremely high. So I don't know, what they were doing in the OR. You're never there. So, I mean, he's a great surgeon, so you have to assume it was done well. But there seems to be a disconnect between these numbers and other numbers we see in the literature, even at long-term follow-up. So I think 41 is, probably on the high side. Now, they also looked at glenoid bone loss in isolation here. And I think we've gotten a little more sophisticated, and we'll focus on the glenoid track, where I think you can't ignore Hagel lesions. You can't ignore bone loss on the humeral head side, and the present. This was a good study to show that, again, a Bankart is not good for everybody, but for me, there are some flaws. And I think the other issue that's overlooked, I showed Gilles' data, which is amazing, but there are complications. I mean, JP Warner, another outstanding surgeon, looked at his short-term complications, and it was almost a 25% incidence. Now, some of them, infection is going to happen with surgery. Some of these were superficial infections, which, again, that's going to happen, but maybe transient crack going for patients, but temporary, so not the worst. Still a rate, non-unions of the graft. So there are issues and long-term complications as well. If you put the graft even a little bit, this is going to really kind of the onset for everybody. I think you've got to do a lot of these like Jill does, like Dr. Gerber does. But be aware there are complications. And even you might say, okay, well, maybe if we do this arthroscopically, that'll mitigate some of the complications that we see with the Latarjet. And this was, again, 2 great studies. Two great surgeons, or a few actually, but George Athwal and Paul Favorito, they looked at short-term complications of the arthroscopic Latarjet procedure in North America. 83 patients, a quarter of them had either a problem or a complication. So problems, again, those sort of short-lived annoyances that you see the patient in the office, but by 6 weeks, they're gone. but 10% complication rate with an intraoperative coracoid fracture rate being 7% shows that even doing this arthroscopically is not a benign procedure. So I mentioned the on-track versus off-track lesion, and I think this is important because it's really showed how our understanding has progressed, and it's not just looking at glenoid bone loss in isolation. It considers how the glenoid and the humeral head bone loss interact, and really it is a bipolar problem. We know that there's a high association of Hill-Sachs lesions with anterior instability, and almost 100% of the time in recurrent instability, but they're not all the same. So Dr. Yamamoto and Okada and Itoi from Japan did the original cadaveric study defining the glenoid tract, and they defined it as the medial margin of the glenoid tract was at 84% of the glenoid width from the rotator cuff footprint. And this was important because it described the contact zone of the glenoid on the humeral head when the arm was abducted and externally rotated. And they found that medial margin was defined as 84% of the glenoid width. Now, we don't have to get too scientific here, but the take-home point was that with decreasing glenoid bone or increasing bone loss medially on the humeral head, it was going to be more likely that the Hill-Sachs lesions are off track, and that's going to be a problem. The risk, and they also made the point that we used to look at the width of the Hill-Sachs lesions. They found that the risk of engagement didn't depend on the width of it, but more how medial the lesion was. So you could have a shallow medial lesion. That's going to be a lot more problematic than more of a broad laterally based Hill-Sachs lesion. And what's, obviously this sounds good in the lab or when looking at CT scans or MRIs, but it's been validated clinically. J.T. Tokish in a study of the US military looked at Bankart repairs for anterior instability. They had almost a 20% recurrence rate at 2-year follow-up. 49% of the on-track lesions, 49 of them were on-track lesions, 4 of which failed. So an 8% failure rate in a very high demand military population. And that goes along with the kind of the numbers that I showed earlier with our arthroscopic Bankarts. The problem was, if you look at the off-track patients, 75% failure rate. So 17% of the non-recurrence group had bone loss greater than 20%. So they made the point that, glenoid bone loss in isolation is not the only issue, and probably not as important as the off-track measurement. Another study by Andreas Imhoff, another great surgeon, looked at a retrospective review of 100 patients treated with an arthroscopic Bankart. 88 of them were on-track lesions, 12 off-track. In the off-track lesion, a third of them needed revision surgery for arthroscopic Bankart. This contrasted with 6% with an on-track. So you're seeing the same numbers repeatedly. Again, I think we're getting more predictable results when we choose our patients better with an arthroscopic Bankart. Well, can we use remplissage of an off-track lesion to restore biomechanical stability? They looked at 8 cadavers, 15% glenoid bone loss, and then looked at an off-track or on-track Hill-Sachs lesion and tested an isolated Bankart or Bankart plus remplissage. On-track lesions, only 1 of them engaged after a Bankart. Off-track engaged in all of them, but then if you did the remplissage, it prevented engagement. So this was a very important study for me to almost justify what I'd seen sort of anecdotally, finding that if you did a little more than an arthroscopic Bankart in some of these, maybe you could convert some of those off-track lesions to on-track lesions. This was a study by a review by DiGiacomo, but he tried to break it down, by bone loss. And I think it does a pretty good job. And now, group 1 was at less than 25% bone loss, on-track lesion, recommended an arthroscopic Bankart. When you get to that off-track lesion with less than 25% of a glenoid defect, and to be fair, this was published in 2014, my tolerance, 25% is still a pretty big glenoid bone defect. I'm probably in that 15% range now. But I would use the same sort of category. And that would be less than 15% with an off-track lesion. I'd want to do something more, an arthroscopic Bankart plus remplissage. When you get to more than 25% bone loss, it's going to be for me a Latarjet. But this is how I break it down, trying to sort of spell out what I'm doing in the middle. So arthroscopic Bankart, up to, that for me, not a lot of bone loss, it's going to work great. And that's that 4% redislocation rate. When you get to 20, 25% bone loss, definitely for me a Latarjet or a glenoid bone graft. It's that middle group, that 13.5% glenoid bone loss, but an off-track lesion, maybe not the greatest capsular tissue, where I'm going to think about doing more. And that's where I'm going to kind of focus on an arthroscopic Bankart maybe plus remplissage, You can consider bone grafting the Hill-Sachs defect, maybe a double row Bankart, or again, Latarjet. For me, if I'm going to do a Bankart plus remplissage, they've got to have good capsulolabral tissue. If they don't, then it's not going to do well, and I'll go straight to a Latarjet. If they, less than 13.5 is what I'm using, but again, 15% is fine for glenoid bone loss. And again, I'll also do that arthroscopic Bankart, but then see if the lesion engages after. That may also help my decision making. Though if I see a medially based Hill-Sachs, and I computed my on-track, off-track, the radiologist will actually do this for me. If it's an off-track lesion with a medially based Hill-Sachs, I'm going to do a Bankart plus remplissage. I don't even stress at my repair anteriorly. I'll just do the Bankart and then do the remplissage right away. I always put pictures in the talk just in case the video doesn't work, but I'll use 2 anchors. Typically, you can see the engaging lesion here, the off-track lesion. You see the Hill-Sachs lesion evidenced by the star there. Two anchors, pass them in mattress fashion, and then reduce the defect. Here's a video. I'm going to skip ahead to the, you don't need to see the anterior Bankart. So now I'm going to go posteriorly. I'm looking from an anterior portal. I typically use a 70-degree scope. I find that it works well to see around the humeral head. This is done in the lateral position. I'm drilling one of my anchors just at the most medial aspect of the Hill-Sachs lesion. And I'm using a spinal needle to pass my anchors. This case, I actually put the anchors in before I tied it down anteriorly, just so I'd have more room to work posteriorly. But a lot of times you don't even need that in a big enough Hill-Sachs defect. Now I've passed my sutures, and now I'm going to go to the subacromial space and tie them. And you can see that I'm compressing. I'm going to make it important. I'll show you a study we did because there's been issues with pain, particularly in external rotation. And here we're probably getting close to the muscle tendon junction of the infraspinatus. But you can see we've closed down that Hill-Sachs lesion. So that looks good to me. And now it's not engaging. That's the infraspinatus remplissage there. Lederman did a study, and we kind of piggybacked on this. He found that, if you're going to do a remplissage, some people, Pascal Below, had a series that showed that there was a loss of postoperative external rotation, and patients complained of posterior shoulder pain. So one of the issues was likely the fact that poor accuracy of suture passage, where the sutures would often penetrate the muscle or the muscle tendon junction through the infraspinatus, or even in 25% of the time through the teres minor. So we looked at this in a cadaver study. We wanted to evaluate the accuracy of suture passage during remplissage and to help identify surface landmarks to help improve these sutures. We found a safe zone where 1 centimeter lateral, and this was done in the beach chair position, 3 centimeters distal to the posterior lateral aspect of the acromion, ended up being a safe zone where no sutures that were placed through there penetrated medial to the muscle tendon junction, compared to 20% in the control group, where we just kind of passed it sort of blindly with a spinal needle, trying to locate it during arthroscopic surgery. But by defining a safe zone, it helped sort of focus us as to where to put the through the muscle tendon junction, or even the teres muscle, which will hopefully lead to decreased pain and decreased external or improved external rotation postoperatively. Looking at arthroscopic Bankart versus Bankart for remplissage for an engaging Hill-Sachs lesion, they did a meta-analysis and found that isolated Bankart had a significantly higher incidence or recurrence of risk and lower functional outcomes. So, doing a remplissage should be in your armamentarium. How about comparing Bankart plus remplissage versus a Latarjet? This was a study done by Gus Mazzocca and Bob Arciero, again, looking at a military population, almost 200 patients with off-track lesions, but less than 25% bone loss. And they compared Bankart plus remplissage versus Latarjet. And they found that in the Bankart plus remplissage group, there was increased pain and decreased internal rotation in abduction, but the Latarjet group had an increased complication rate. Outcome scores were the same, and no difference in revision rate or recurrent instability. They did find that Latarjets were better in contact or collision athletes in cases of more significant bone loss. So, it's studies like these that help guide me. I think, there's no hard and fast rules here, and you're really trying to, sort of walk a tightrope and try to figure out what to do. But I think I always want to decrease my complication rate while providing excellent outcomes. So I think for the appropriately chosen patient, doing a Bankart plus remplissage for me is, works very well. And I use it a lot of the time in lieu of many people using a Latarjet. How about a double row repair? And this could be done open or arthroscopically. I do it for on-track lesions, but maybe if they have a large Alps lesion where you've got a lot of the neck of the glenoid exposed, and also there's contact athletes. Laurent Lafosse was one of the first to describe this. He described the Cassiopeia double row technique. And look, it's very similar to what we've done with double row rotator cuff repairs, better recreating the normal anatomy. And if you look at like the depth of the capsule attachment along the neck of the glenoid, when you go from, sort of 4 o'clock to 6 o'clock, which is your typical Bankart lesion, it's not just a point attachment along the, just off the face of the glenoid. There's, about a centimeter of attachment of the capsule to the bone there. So we want to recreate that, and the double row repair does that. We looked at this in the lab as well, which we published in it. I'm sorry, this is a study by Kim, but we looked at it in the lab as well. But very similar again to what you see with rotator cuff studies, which is the better recreation of anatomy with better contact pressures, which will likely lead to improved healing. We did this in the lab again with Ty Lee out in California. We did it and then looked at the biomechanics of a double row repair. Ultimate load to failure and yield load were both significantly stronger in the double row group. Video was not working, I apologize, but this is a view from lateral, looking at the anterior superior portal, looking down. This is your neck of the glenoid there anteriorly. So here's your capsular tissue, which is good. No significant bone loss, but a big Alps lesion. So you can see the amount of exposed bone there along the neck of the glenoid. So if I just brought this up to the face of the glenoid here, you're gonna have this whole area where there's no healing. And that's why the double row makes sense to me here. Elevating the tissue, I'm gonna put one anchor pretty medial on the glenoid, which I'll then shuttle, standard fashion, and then bring them up over the top again like a double row and fix the anchors to the lateral row with a knotless anchor, and it works pretty well, and it's technically pretty easy. So to conclude, and I wanted to save a couple minutes for discussion on this or questions, the Latarjet works well, and in some hands like Jill Walsh or Professor Gerber, it's outstanding. But there are complications, and they're difficult to revise. You don't have a bailout, necessarily. And the issue is not everyone needs it. I think we can get good results with an arthroscopic Bankart and even adding a remplissage or even a double row repair in cases where there's not significant bone loss or off-track lesions. And so I think it's something to keep in your armamentarium. Thank you. Was that okay? Could you guys hear okay?
That was brilliant. Thank you so much.
So should we do some questions if people have it?
Can you hear me?
Yeah, perfect.
Yeah, brilliant. I'm Puneet here. So, brilliant lecture. I think a lot of thought-provoking points you made. I just wanted to ask you about something which we've been thinking about recently. Like yourself, Latarjet has been our workhorse for most of the bone loss patients and a lot of contact athletes. We've been thinking about using bone block a lot more. Now, I see you've done a really nice study looking at what gives Latarjet the maximum effect. Is it the bone loss compensation? Is it the bumper effect? Is it the sling effect? What are your thoughts about performing a simple bone block for glenoid bone loss?
It's a great question. I mean, some people, to your point, have talked about almost, making the Latarjet your bailout and doing sort of an Eden Hibonette first, which on a lot of levels makes sense. It's more anatomic. You're not disrupting the anatomy. But I think you raised a great point, which we tried to sort of elucidate in our study, which is, I think you have to look at each case individually. So for the bone loss ones, which is not what we looked at, we looked at capsular insufficiency. I think if you have a capsular insufficiency one, doing just a bone block, probably not adding very much when you haven't lost a lot of bone on the glenoid. But if you do have the bone loss cases, then I think, doing a bone block makes a lot of sense. And we're actually looking at this in the lab right now. Sam Taylor, a colleague of mine, is doing great work on this, looking at kind of the contact pressures in different degrees of bone loss, anywhere from 10 to 15 to 25 to 35, depending on how much you're replacing, to see how much load that bone block is going to take to see, how well it's going to incorporate potentially, so that we can start using it a little more aggressively, maybe in lieu of the ladder J. Because, part of the issue with, we debate this in our sort of shoulder conference all the time. Some of my more, kind of older colleagues who've been around for years, who didn't train on arthroscopic surgery initially, will often, go from an arthroscopic Bankart to an open Bankart to a ladder J. And it's funny because some of my young colleagues, my generation, I say, look, I readily admit, I think I can do a pretty good arthroscopic Bankart, or maybe Bankart plus remplissage. I can do a pretty good ladder J. I don't know when I could do just an open capsular shift and when that's doing more for me. For me, it's, if I'm doing something open, I'm probably going to go to a ladder J. But, in line with your question, maybe you're getting the benefits of an open, you can obviously do the bone blocks arthroscopically, but if you do them open, you're getting the benefits of the bone block, better recreating the glenoid anatomy. And then you're also doing, theoretically, some element of a capsular shift. And so that's probably all you need. You probably don't need to do a ladder J in all these. And I think that's the point of my talk, which is not everybody needs a ladder J. Now, I wish I could give you all the answers and tell you for each case what exactly you need. And that's what we're still trying to figure out. And probably in the future, machine learning and things like that will be used to pick the best procedure by, and they'll be able to kind of, sort of integrate all the different variables. But we're not there yet, but we're hopefully getting on it.
Like, you know what I mean? Like this.
Hi, Josh, it's Mike Walton.
Hi, Mike.
So we've never really adopted the arthroscopic ladder J, largely because our results with open have been good and we've found it to be an arthroscopic leap too far. But ultimately, it may be that the arthroscopic ladder J do arthroscopic bone blocks more effectively, that it does become an arthroscopic in between, and the ladder J is your default open operation later.
I think that's a great point, and I think I agree with you 100%. I mean, I think, in good conscience, I have a hard time doing arthroscopic ladder J, not from a technical standpoint, but usually I've had with good surgeons, sort of the learning curve is very steep, and they had a very high complication rate in their first whatever number of 25 cases. So especially here in America, where I'm doing 90% of the time doing an arthroscopic Bankart, if I'm then going to take the 10% where I'm doing, or let's say 10% of my cases are ladder J's, I don't want to sort of do a poor job on those patients that I'm indicating for a ladder J while I'm getting up to speed there. When, to your point, I think it's almost a little bit of technology over reason. Now, using a bone block, putting that in arthroscopically becomes a great way to do it. I agree with you 100%. So I think that, when I have better pictures and a little more data from what we're working on, that becomes a great, another 3 or 4 slides in this talk of something that you can do short of a ladder J. And to your point, I think it's great. Make the ladder J your bailout.
Josh, we got a question in the Q&A from Andy Wright, one of our new colleagues at Wrightington. He asks, is there a situation where you consider a humeral head bone graft over remplissage for a large or very medial Hill-Sachs lesion?
That's a great question. It's very rare. I mean, those are really big lesions. I've seen, I'd be lying if I said I did a lot. That's one of those things that I do probably once every, 2-3 years. And I do a lot of shoulder surgery and a lot of instability. But I think, if it's clearly a big, I will fill that defect, but I just don't see those that often. So I've done it. It should be in your armamentarium. Those are ones where, though, if I'm doing that, I'm probably doing that in conjunction with a ladder J, as opposed to like an arthroscopic Bankart and a bone graft on the humeral head. But it's when you get to kind of like 30% defects on the humeral head where I'll have an allograft available.
Fantastic. I went out for a little bit, so sorry about that. My connection.
That was where I gave that's where I explained everything. So you missed it. But we'll do it again.
Yeah, one of the things I was going to ask you is you mentioned about your measurements, that you take measurements for the on track, off track, and that's done by your radiologist. What technique do you guys use off the MRI scan?
So yeah, so and a lot of the time, again, it's almost easier off a CT scan, but we've worked closely with our radiologists, and we really just do what Etoy described, I'm pulling it up. Oh, I share my screen because he's got it, he walks it through the measurements pretty well. Hold on one
Okay,
second.
I'll
show
set
you.
you up.
Okay, I'm gonna share my screen. I'm sharing my screen. Bear with me one second here. So, this is nothing I created, but this is what, Giovanni Giacomo and Etoy described initially, but you're going to measure the diameter. And again, you could do this arthroscopically, but I don't. This is typically done preoperatively. They described it on a CT scan, which I do think is actually easier. But it's not something that I actually sent, if the patient, a lot of the patients have come in with an MRI, I'm not going to send them for a CT scan also if they've already done the MRI. But if I see, if they've got a history classic for instability and I can see a decent amount of bone loss either on the Hill-Sachs side or the glenoid based on plain films and they have not had any advanced imaging, I will do a CT scan. And then I just go through this. I don't know if you can see table 1 here, but basically, you determine the width of glenoid bone loss. And then the width of glenoid tract, which is that 0.83 number I was talking about before. So it's the diameter of the inferior glenoid times 0.83 minus the glenoid bone loss. And then the Hill-Sachs is measured between the bone bridge there. So it's the Hill-Sachs lesion. It's the width of the bone bridge between the rotator cuff. So you're looking at the cuff attachment on the greater tuberosity and the lateral aspect of the Hill-Sachs lesion. And if that's greater than your glenoid tract number, so if your Hill-Sachs lesion size is greater than your glenoid tract, then it's an off-track or an engaging lesion. It gets very granular. Again, I don't have it memorized. I literally have this in front of me when I do it. And it was even better because now I have the radiologist do it because they love doing this. It's great. They get very excited to report the on-track, off-track lesions. But we sat down the first couple times together, and now they love reporting it. Just like, we've got them looking at, glenoid morphology for total shoulder. So they love talking about version now and trying to classify it. And obviously we don't always agree, but I think getting involved in the decision-making process, they found it, educational, and they also like to then get some feedback of what I'm seeing arthroscopically. That sounds like a question. That's a very astute question. I can't answer it.
That was actually all in Dog, and what he wanted to know really is how much in your decision making emphasis do you put on these measurements versus the patient factors, the age, the sports, the hypermobility, and those sort of factors?
Yeah, that's a great question. I think, it's a great question because that's what, ASES is looking at that, trying to, come up with a Delphi analysis of like, what's most important. And, what I find frustrating, I love treating instability, but what I find most frustrating is that there's no great algorithm. And this becomes kind of more the art of medicine as opposed to the science. So all those numbers help guide me. But I think the patient factors first and foremost are what are most important, age and activity level, because you know what, to make it easy, if you take one, if there's a 60-year-old, or not even that, if it's a 40-year-old with, a 13% bone loss, or even let's go to 15% bone loss, they're low demand, but they've had recurrent instability, but they've got good capsular tissue. I'll probably just do an arthroscopic band card there because that group's going to tend to get stiff anyway. The results are pretty good. So, not that the numbers don't matter, but would matter less than in a younger patient. I do like to have the numbers, it just helps guide me on those because look, a lot of this is when you're dealing with these shades of gray. I think, what we're starting to work on is, doing some studies using machine learning, which also is way above my sort of pay grade, but I work with a great resident who's put a lot of work into this. And I think that's going to then tell us what factors are most important. And maybe it's different depending on different, the numbers may matter more in somebody who plays American football than somebody who plays or rugby versus somebody who plays American baseball. So I wish I could give a great answer. The problem is I'm kind of all over the lot and it's really the gestalt. And a lot of it is also here, the discussion with the patient, and not that you should let them dictate the treatment, but a lot of times I'll tell them, look, you could do this arthroscopically or open. I give them the risks and benefits, give them the numbers. And a lot of times, they want to go with an arthroscopic procedure because open sounds barbaric, or, you're taking a piece of their coracoid and moving it. It sounds, non-anatomic. So I think a lot of it is my feeling for the patient, how active they are, how compliant they are, what they like to do. B is kind of the measurements. And then C is the discussion with the patient and seeing if that kind of tips the scales one way or another. But that was a long way around avoiding your question.
Can I ask a question then? I've got a question about return to play. Of all these procedures that you do they factor in when you allow your patients to return to sports? And love to hear your thoughts about what factors you consider when they go back to full contact, and how do you decide when they return to sports?
It's a great question. Ironically, I kind of use the same protocol and give the same outline for both, whether it's an arthroscopic Bankart or a Latarjet, to use those two. And I know some of my colleagues will get a little more aggressive with a Latarjet. But honestly, I think maybe it's the bias of the cases that I'm doing a Latarjet in are sort of almost more severe instability. So I want to go a little more slowly. And I also look, you're doing this in young kids. They're not the most compliant as a group. So I don't see any upside in letting them go a little more quickly because I did one procedure or the other. Now, I tell them, look, first 6 weeks, we're going to go slow in a sling. You can do things below shoulder level. That's when we'll get much more aggressive with range of motion. I tell them by 3 months, we're going to really kind of take off the restrictions and start loading it a little, with the goal being by about 4.5 months, sort of easing back into contact sports, whether it's basketball, football, and by 6 months, they're playing unrestricted. The one thing that I do like about a Latarjet, as opposed to sort of arthroscopic Bankart, is the Latarjet, one of the things I'll use to kind of hold people back, because they do want to go back too quickly, is I will get a CAT scan if they're trying to sort of push to go back to contact sports too soon, or I just want to slow them down. That's where I'll kind of get a CAT scan and even delay getting it authorized and stuff to buy myself a couple of weeks. And I could say, look, it's still healing. Let's wait a couple of weeks. I don't have that luxury, in an MRI per se. You could do it, but they never look great. They'll make some comments like, can't rule out a labral tear. But at least with the bone, you can sort of see if it's healed or not. If it's healed, they're strong, they've got good motion, and that's at 4.5 months as opposed to 5 months, I'm fine with her going back unrestricted.
That's brilliant. Thank you.
Josh, to follow on from that, do you think that's the standard in the US? Is that the approach most people take?
I think, well, it's funny because I think, I'm going to talk out of both sides of my mouth. I think on the early side, some colleagues of mine do get more aggressive with a Latarjet right out of the gate. They'll allow them to start moving more because I figure you're getting, bone to bone healing. You've got a screw there, almost treating it like a fracture. So they'll get a little more aggressive. I think I might be a little more aggressive on the back end. That kind of, 4.5 months is early. But between 5 and 6 months, I'm letting them go back. I do have some colleagues who will say, kind of 9 months. My feeling is that, if they've got full strength and motion and things are healed, I don't really know the difference between 6 months and 9 months, where I'm going to kind of hold them back.
Certainly, we find it's very hard holding them back.
Exactly.
Once they feel ready, which is well less than 9 months usually. So do you feel more confident letting Latarjets go back earlier than arthroscopic Bankarts, or the other way around?
Honestly, the other way around, because I think if they sort of, have sort of some event, even like a subluxation or like a little pain in an arthroscopic, I don't think that, it doesn't, there's potential they didn't ruin everything. If the Latarjet goes bad, it goes bad. You see the bone floating there, you could break screws, it could go bad. We have the same problem as you that you were just mentioning, which is people are sort of not very compliant. So when I sort of see that, I think, again, for the trainees, we have the luxury, like I can get an MRI the same day if I need it on somebody. But what I'll do is, if I kind of looking ahead, if it's somebody who is going to be kind of aggressive about going back, I typically see patients in about a week after surgery, 6 weeks, 3 months. And then at around 6 months, but by then they're not even coming back because they're doing well. When the Latarjets or the stability group wants to get back early, they'll often try to come back in at around 4.5 months to push it. And what I'll do is I'll have my office, say I'm busy or a little, and make them wait an extra week or two. and then maybe, get the CT scan and then review it with them. So I can almost buy myself sort of 2 or 3 weeks extra just in terms of scheduling, which I'll use when I don't think they're going to be the most compliant.
And do you routinely get CT scans before deciding on returning to play, and you want to see union before returning to play?
Honestly, no, because unless, again, I'm going to use it to get them back a little, if they're trying to get back early. Because look, there isn't a reported non-union rate, just in the literature after Latarjet. If clinically they're doing well, that may never go on to union. And if I'm not going to revise it, I'm not going to, that CT scan doesn't do anything for me. So, and in those cases, look, maybe it is the sling effect that's working. You've got a couple of things working. So even if you don't have a union there, if it's not a symptomatic non-union, and I'm not going to take them back to the OR, then all getting a CT scan does there is open up a, Pandora's box for me. So I don't routinely get one unless they're kind of pushing to do more, or I have a clinical concern. What about you, Len? Do you get one on everybody before?
No, I don't, but I do know some surgeons who do. My question always to them is, what happens, what do you do with the cases who've not fully united and have no symptoms and are ready to return to full play? So
what's your answer? That's my point in not getting one, because I don't think, it's just, you've got the parents who've now come in with the CT scan report printed and highlighted and annotated, and it's a disaster because you're not going to do anything. And you're trying to explain to them that we went through this, we moved this bone there and put a screw in to get it to heal, but it didn't heal, but they're fine. And it becomes, a half hour of my life I'll never get back in the office.
And it becomes very difficult mentally for that guy if you do say sometimes you can go back to play. So there's a lot of implications. We've got another question. This is from Krishna Swami, who's one of our colleagues at Wrightington. And he said, what percentage of the patients in each group, so your Latarjets, arthroscopic, Bancarts, and remplissage, develop early OA, say in their 40s?
It's a good question. I think the good news is, I've only been in practice for about 12 years, so I haven't seen a lot of those yet. I'm sure they're coming. But we looked at our total shoulder registry, and this is not, you don't know the denominator, but ironically, it was a very small percent, and we have, probably 2,500 or 3,000 total shoulders in our HSS shoulder registry that started probably about, 6 or 7 years ago. There was only about 50 or 60 patients who had a total shoulder arthroplasty, sort of post-capsulorrhaphy shoulder arthroplasty. Now that doesn't mean, that's not answering your question, but I think if you stabilize them, and these are, athletes, it's not a foregone conclusion that they're going to go on to arthritis. The irony is, it's a great question, and it's something I'm interested in. We're actually we're looking at circulating biomarkers on my patients with instability. We're going to submit it for publication now, looking at first-time dislocators versus multiple recurrences, seeing if there's an increased circulating biomarkers of COMP and all these other sort of metabolites that may be associated with arthritis, and maybe use that as a sort of part of your decision-making process. Because if these circulating biomarkers are going up in the setting of repeat instability, maybe it would make the case that you should sort of stabilize them earlier to prevent that long-term arthritis. So we're looking at that at a sort of a basic science level, but I don't have that. Hopefully, if I get invited back, I'll have that data for you.
That's very interesting. The other interesting bit will ultimately, would you be able to influence that?
Right.
With surgery. So let's get before we get those.
The other thing I was going to comment on, Len, that you made, I know we're running out of time, I apologize, but the other comment to make, with the CT scan after a Latarjet, again, it's really cut and dry whether it healed or not. You asked if I let, I don't image the labor repairs. If they do, those are actually easier to kind of look. I tell patients all the time, it's never going to look perfect. So even if they say a little scar or a little, diminution of the labrum, like that's almost an easier conversation to have with patients if it's not clinically relevant than, again, the non-union of the Latarjet. So I don't go looking for trouble.
Thank you very much. Sorry, I'm just muting myself at times because of the dog barking. So I think it might be interesting for you and also for me to run a poll and see what other people's practices are and their experiences here. So
That'd be great.
all the
You
attendees.
have, I don't have, you have the, I think you have the poll as the hosting, right?
I'm going to launch it in a second. It's launched now.
I've gone off. Okay.
Somebody asked while we're doing this, I don't know if you can hear me, but somebody asked about 3T MRIs versus MR arthrograms for instability. We typically, just as an institution at HSS, Hollis Potter, who's, as famous an, radiologist as there is, really is adamant about avoiding arthrograms. And so we usually get 3T MRIs and can see things pretty well. That said, if I'm going to send somebody to a place where, they've had previous surgery, and I don't know the MRI place or it's not great quality, then I will have them do an arthrogram, then I'm fine with it. But the other issue with an arthrogram is, look, it's not a benign thing. Their shoulders are sore, especially when you're doing the athletes. Like, we avoid it in baseball players because then their shoulder, you get the MRI, the arthrogram hurts them more sometimes than their actual shoulder pain. So, and if they put it in the wrong place, it's not great. So we usually just use 3T MRIs and it works well. But if you don't have that, I think it's very reasonable to do an arthrogram.
Yep, I agree. What, Mike and Puneet, what are your thoughts on that?
On the question of MR arthrogram, I think we still, I personally would usually go for an MR arthrogram for most of the instability cases. We've been using obviously the CT arthrogram when there's been a previous surgery or when there's a clear evidence of bone loss on an X-ray.
Yeah.
So the best of both worlds.
You guys are actually, I don't mean to stereotype, but you guys are, just in Europe and elsewhere, are just much better with CT scans, even if for evaluating the rotator cuff. And I think it's a skill, which, I just don't use it a lot, so I'm not very good at it, which, so it becomes a problem.
I know I would never use a CT to evaluate the cuff like they do in France.
Yeah.
But I think we're lucky. It depends upon our access times. If the more closer to the injury, the better a plain MR is, and the more away from the injury, the more I find an arthrogram useful.
Yeah.
Particularly if I'm concerned that there's posterior superior tears as well, because I find that plain MRs don't pick up posterior labral tears at all.
Yeah. And again, Hollis is very adamant, like that she could see it, but right. Look, I tell people there's still those, if I see a lot of shoulder patients a year, it's clearly misses some to, this posterior supralabral tears that you're talking about. So, that's a percent. I have to explain to patients, look, MRIs aren't perfect for this. And then at that point though, is it worth getting an arthrogram if they've had one, and it's, it becomes almost more of a clinical discussion for me. But that I definitely have a lower threshold to get the arthrogram if it's somewhere where I don't trust the radiologist or if it's less than a 3T magnet.
There's always obviously another issue that even with a good MR arthrogram, there's a chance of missing a labral lesion.
Yes.
The sensitivity of even a best MR arthrogram is what, 85 to 90%.
Not perfect, right? So a lot of this is clinical, and that just kind of helps the decision making.
Yeah.
Here's something totally off track for us. Are you back operating yet? And what's your plans for returning to elective surgery in the COVID era?
Yeah. So we the first kind of, from March 16th to sort of May 4th. So for about 6 weeks, it was just sort of essential, sort of emergent surgery. Starting a week and a half ago, it moved to urgent, which are, things that if you continue to wait, like somebody who tore the rotator cuff, acute tear, know how long this would last. If it's going to start waiting 3 or 6 months in a young guy with an acute rotator cuff tear, now you can make the case to do that. Or if they're starting to develop pain medication habits. So that's been the last 2 weeks. Going forward, starting next week, because we've now got enough, PPE, we've got enough anesthesia machines, and we've also done an initial study looking at 30-day outcomes at HSS on all the emergent surgeries that were done and compared it to matched controls. No increased complication rate in the in the COVID era, even with COVID patients. So because of that, they felt much safer just kind of opening it to elective procedures. That said, they're still recommending that we do younger patients. They don't want anybody over 70 being operated on yet. So it's going to be a slow rollout. We're getting back up to speed, but it's going to be probably, the end of the summer before it's, who knows, maybe even normal.
Are you screening your patients, and are you screening staff?
Both. So all the staff has been screened, and then they get temperature checks every day when they walk in. Patients, the day before surgery with it, not 24 hours, but the day before, the calendar day before, they get a chest x-ray, pulse ox, serology testing, probably just more for academics than anything else, and a PCR test. If the PCR test is positive, case gets canceled, and they then have to have, be treated or whatever. They then have to have 2 negative tests before being scheduled again.
Okay.
What about you guys?
We're having all these conversations at the
I
moment
know.
to work out how to do it.
It's not easy, and it's a moving target. I mean, by the time I get off this call, it might have changed.
We're in a dichotomy, really, that the cases which seem intuitive to do, which are the most urgent, tend to be the most frail.
Right.
And the ones which are probably the safest are our arthroscopic day case ASA1 patients, who are the less urgent. And so there's a balance to be played.
Now we have the same sort of conundrum. So I apologize. I'm supposed to be on another call at 2 o'clock.
No.
So I apologize that I have to run.
Well, thank you very much. We have just overrun our time.
Thank you.
Massive thank you
No,
to
thank
you,
you guys so
Josh.
much. Great seeing you, and hopefully see you in person when this is behind us.
Well, hopefully we can get
Thank
you
you so
back
much.
for your biceps talk at some
For
stage.
anytime. No, honestly, this is easy to do. Work great. So you let me know.
Thank you
Cheers,
very
Josh.
much.
Thank you very much.
Take care, guys.
Cheers. Bye.
Thanks.
Well
to
done, Len. Thank you.